Sounds good to folks. So welcome everybody. My name is Sohail Sood, UCSF faculty and pediatrician. My pleasure to welcome you to our ongoing series of the Global Child Health Lectures. Today, this morning, we are, well, good morning in California. I know it's good evening and good afternoon in other parts of the world where folks are joining us. My pleasure to introduce Dr. Josh Bress and Dr. Mary Muhindo today, who are going to be talking about something that I would say is not covered in most global health curriculums, but really underpins so much of what we do in clinical medicine, which is the concepts of software and algorithms, those pieces that we turn to when our minds are at a loss for what to do next. And so for the sake of time, maybe Josh, I'll turn it over to you to provide a little bit more context, if that sounds good, and to introduce Dr. Mary a little more.
Sure. Well, it's a pleasure to be back again this year and to introduce Dr. Mary Muhindo. She's based in Tororo district of Uganda. For those of you who've been there, she's the principal investigator of the first and second of the NoviGuide software studies. And I'll turn it over to her to start us off.
Okay, thank you so much, Josh. So let me just briefly show my face, and then you'll allow me to switch off my video so that I do not interfere with the network. I'm really excited to be here with you, and I would like to share a brief overview about our work of studying software and global health. Then, of course, together with Dr. Josh, we'll share some of the lessons we've learned over the years studying NoviGuide. Next slide, please. So I live in Eastern Uganda, in Tororo, and this is a rural area that really shares many challenges of rural areas in Africa. And my community has had problems that software was well positioned to solve. First, we needed a tool that was tailored to our resources. I mean, our hospitals are completely different from the ones in Kampala or the more urban areas. So we needed a tool that would give us guidance depending on the resources we have in our rural setting. And secondly, we needed to be able to detect the gaps in care at a site level. So rural areas are vast and travel is expensive. So we needed to be able to detect these problems remotely. And thirdly, we needed a way to integrate new equipment seamlessly at our hospital. And as I'll share later, this is what I'm studying currently with pulse oximeters. Next slide, please. I'm now going to hand over to Dr. Josh to give you a brief demonstration of a NoviGuide entry so that you can have some context before I talk more about our work.
Thanks, Mary. So we thought that, as Mary presents her work, it would be helpful first to just see the software itself so you have some context for it. We won't spend a lot of time here, but just so you can envision it as she describes her studies. The NoviGuide is what's called a clinical decision support software. And what I'm going to show you here is sort of what a midwife holds. So when Dr. Muhindo has been studying the NoviGuide, she's studying midwives who are holding this software. The software guides people through newborn assessments. I'm not going to go into the details of the clinical medicine here, but this is a video I filmed of myself entering in a sick and small preterm baby. I'll just only highlight for those in the audience, this is the #1 cause of child mortality in the world, the preterm birth. As you can see, the NoviGuide kind of walks people through an assessment. It opens and closes lines of questioning in response to danger signs and directs someone kind of in step-by-step care. There are two features of NoviGuide that really make it unique in the field of decision support software and global health. The first is something that Dr. Muhindo mentioned, which is the guidance of the software is tailored to the site's resources. This is like a key innovation. We're not going to discuss the back end of it, but just know that here, sick preterm baby, the NoviGuide tells you to check the oxygen saturation level. No, if you could not check that, you would not see this. That's like a key innovation that Dr. Muhindo has been helping us evaluate. The second aspect of the software that makes it unique is its depth. Most software in global health, I would say even still today, is designed for the community healthcare worker user, who if they encounter a sick baby will be instructed to refer that baby to a hospital. This software sort of picks it up from there, provides hospital-based care, including really advanced features like contextual drug dosing, which nurses and doctors really appreciate. This goes sort of all the way through and has the sort of depth that you need at a place like a district hospital. Here we show standard antibiotic dosing calculations, but not just the dose in milligrams, but all the way down to how to prepare the vial size, things we never have to learn when I was training at UCSF, how to prepare it and administer it based on the age and gestational weight. So this is the software that Dr. Muhindo has been studying there. I'll let it conclude by showing you that there are features of this that are even unique in the United States, in the ability to auto-populate a problem list, report back on stockouts, etc. Okay, I think what I'll do is I'm going to stop this and then go back to the presentation. So some advanced Zoom.
Okay, thank you so much, Josh. So our first evaluation, next slide, please. Our first evaluation was testing acceptability and feasibility, like all other beginning evaluations. So we conducted this in Tororo District Hospital, and we published our work showing that Noviguide was acceptable to the nurses and the midwives, and it was feasible to implement in a rural district hospital. So the nurses really loved Noviguide, and what they loved the most was the drug dosing functionality. So we implemented Noviguide using a strategy we call voluntary but encouraged. So that means that we encourage the midwives to use the Noviguide, but did not force them to use it. So they really use it according to their discretion. And with this strategy, nurses entered over 1,700 neonatal assessments into Noviguide, really preferring the sick babies and those that had risk factors for neonatal assessment. Next slide, please. So following this study, we are now studying whether Noviguide can be used to facilitate the implementation of neonatal pulse oximetry. And as Josh said, Noviguide gives you guidance tailored to the resources you have available on site. So it's therefore possible to introduce a new equipment on your site simultaneously with a decision support tool about its appropriate use. So to date, over 4,600 neonatal assessments have been entered into Noviguide. And of course, I'm also excited to let you know that Noviguide is being used in the United States too. Next slide, please. So I'll now go ahead and share our lessons that we've learned over the years. Lesson number 1. Next slide, please, Josh. So unlike lesson number 1 is studying software requires knowing how that software is built. So unlike studying a drug, software can be modified. Indeed, in many cases, what we are studying is which modifications to make, but there are limits and consequences to each modification. So as a researcher, I have to know what those limits and consequences are, even if I'm not the one who made the software. Lesson number 2 is, next slide, please, Josh. Software's impact is not simply the sum of usage data plus some clinical outcome measures. So when you study software and publish it, you're often publishing the usage data, that is how often the people are using the tool, and some outcome measures. For example, in our first study, we tested usage and nurse knowledge using a questionnaire. This is very important, but it doesn't fully capture what happens when you give nurses a tool like Noviguide. So from our observations, we now know that software like Noviguide is a conversation starter. It's a quality improvement project by itself. Just when you see the nurses interacting with it, there's a way they talk amongst themselves on how to improve the care they're providing in like a rural hospital like where I work. Secondly, using at its usage alone, there are variations in use among the users. So, but for some nurses, those that really take it up, these become champions of a major and very positive change. And concerning confidence in care, it's very difficult to express it in a research study. Of course, in our first study, we asked the nurses and midwives to rate their confidence on a scale of 1 to 10, and their confidence to care for newborns before we introduced Noviguide and during and after its introduction. But of course, that's really different from seeing improved confidence in the hospital. For example, one midwife before Noviguide always avoided newborns and awaited a colleague to come and review a baby. But now with Noviguide, they can confidently care for a newborn with Noviguide. So this is not easily captured by just reviewing the usage data. So let me just read for you some 2 quotes from the focus group discussions we've had when we asked the midwives and nurses how they felt. So one said, the Noviguide has improved the care of newborns. Me, I could go for paracetamol in case of a high temperature, but Noviguide tells me what to do. And in my assessment of this baby, it guides me to be systematic and it takes me directly to the medication to give. Another said, Noviguide has also helped me care for newborns requiring oxygen therapy. Yesterday, I got a 1-day-old sick newborn with a history of spiking fevers and refusal to breastfeed. On examination, she was sick looking with a temperature of 40. I Noviguided her, and when Noviguide asked me for an oxygen fat level, I checked it using the pulse oximeter and it was 85%. I quickly put the baby on oxygen. I would never have known about the low oxygen if Noviguide did not ask me for that level. And of course, the nurses have owned it. I mean, it's now a verb. I Noviguided this baby. That is how confidence has improved amongst our midwives and nurses using Noviguide. And my third lesson is, next slide, please. We need more people working on software in health. More diversity is urgently needed. In a small way, my work has shown what happens when people not traditionally involved in software work and get a seat at the table. For example, myself. When you have diversity at the table, you get better feedback about the product. That feedback leads to better software, and that engagement leads to people really invested and becoming local champions. And so I will now hand over to Josh so that he can also share his lessons learned over the years.
Thank you, Dr. Muhindo. That was wonderful. I'm going to add in, I think, lessons from the software design, development, and implementation side. I think will complement some of the ones that Dr. Muhindo mentioned. And my grandma always used to tell me there's lessons you learn the easy way and lessons you learn the hard way. And I would probably put almost all of these into the hard way category. I would say if you take one thing from what I say, I would say it would be this first slide. When software really needs to be designed for users and not as solutions to specific clinical targets. I would say this is a lesson I've learned continuously over about 5 years of doing this. And I learned it from Dr. Muhindo and her team, which includes 2 nurse midwives, Sister Ateem and Sister Beatrice. What do I mean by that? When we first came up with the idea for the Noviguide, we described it as something like this. This is a software application that's going to improve newborn care by increasing fidelity to newborn care guidelines. Its targets are neonatal infection, prematurity. We talked about it in that way. 2022, 5 years later, I realized just how wrong that paradigm is. There is no person out there who, in a rural district hospital who purely sees newborns. The very users in our study see newborns about 30 to 40% of their time. Most of their time is spent doing vaginal deliveries. This was just extremely eye-opening to see and to realize that our paradigm was just really off. To highlight this, I pulled up 3 research articles, and ours is number 1 to show you that we're guilty of the very thing that I'm now trying to change, which is if you read these 3 titles, and I'll just read them out for you. The first was our own software, implementation of a newborn clinical decision support software in Eastern Uganda. The second and third are also decision support, but they're not our work. Effectiveness of a decision support system in improving the management of childhood illness. And the third, decision support for acute burn referral. What do these 3 titles, with ours again at the top, have in common? something our program manager, Jean, would tell me, it's missing the human language. These titles are almost from the makers of clinical notes. The baby was given ampicillin and gentamicin instead of we gave the baby ampicillin and gentamicin. There's really no people in this. And that matters. This is how, and I'll explain why I think it matters. If I could rename our title, I would say implementation of a decision support software for midwives who care for newborns in a rural district hospital. The reason this matters is because if you think of software as going after clinical targets, that is what you will make. You will make narrow software that addresses a single problem that a doctor or nurse has. But for those of you who are clinicians in the room, we don't see single problems. We see a huge diversity of problems. In places like Tororo, that diversity is even more. People are true generalists, the type of generalists you would find in the rural parts of the United States. The second lesson I would say is one I wish I didn't learn because I just wish it wasn't true, but it is true and I've had to learn it, which is that people are highly skeptical of digital solutions. They're predisposed to be skeptical of digital solutions. I've been fortunate to have a now 10-year career in global health, and I've been part of many projects. Some of those projects I would describe as traditional, like giving a scholarship to someone to get a specialized training. Others involve medications and traditional care or direct care provision. And some involve technology. And I can tell you, I never encounter the degree of skepticism that I encounter in our digital work in those others. Just to put you in my shoes for a second, imagine that you're me and you are explaining a digital software 2 to 3 times a week to someone who's never seen it, and you're trying to convince them of its value. I'm commonly asked questions like, do you think people really pick this up? Do you think this is feasible to do this? So everyone's going to have a tablet? Like, how is this going to work? And though I answer those questions with seriousness, in the back of my head, I am thinking, I'm talking to you over Zoom. Technology has permeated our lives. Where is the skepticism coming from? It reminds me of the parable of an old fish swimming by 2 young fish. And the old fish says to the young fish, "How's the water, boys?" And the 2 young fish swim off. And one turns to the other and says, "What the heck is water?" It's like the technology is everywhere that we can't see, that it would be obviously needs to be applied in medicine. However, learning this lesson was ultimately beneficial to us. The reason is that I no longer go in expecting the technology to speak for itself. I would say a common mistake I made early on was to describe it like this. This tool is like Google Maps. It's going to take a paper guideline and make it into something that's interactive. And like Google Maps, it's going to prevent people from getting lost. I now explain it like this. Following guidelines is a global problem. And the way people are solving this problem right now is with large PDF documents. And the reason that's not going to work is this, ABC, really walking people through the logic of why you would not want to have a large PDF or a WHO toolkit as your solution, and not assuming that people are going to immediately see what you see in the technology. The other thing I would add is like some humility is that we look at Google Maps now and think this is great, but there was a time, I'm old enough to know, when Google Maps was not quite as great, when you had to print it out, for example, or print out MapQuest, and just recognizing that we're closer to those days than we are to like the fully functional tools we now use. The third lesson we learned, and I actually don't know the meaning of this lesson, but I thought I would share it and maybe it would prompt some discussion, is that we spend a lot of our time communicating about our work, and we get asked a lot of questions about that work. And there's actually now, I would say, a widening gap between the questions we're asked about the work and the questions we ask ourselves internally, behind the curtain, about the future of our software and the work within it. I would say this is analogous for people in clinical medicine to like a specialty. I'm a pediatrician. If I call a pediatric infectious disease specialist, I have like a certain type of question I'm going to ask. but pediatric infectious disease specialists among themselves are asking a different type of question. For me, it's just this recognition that, in 10 years, could there be someone who is a specialist in software, human factors, design and medicine? And that's a slightly different specialty than informatics. In fact, even the term informatics sounds older than what this is describing. To highlight this, I thought I would just go through some of these questions just so you can peek behind the curtain a little bit about what it's like in the software and global health world. Far and away, this is the number one question we are asked. Does this software that you've just shown, whether it's a newborn version or a maternal version, does this software work offline? And almost always the reason this question is asked is because we've just forgot to mention it. Of course, it has to be. It's a prerequisite. And every single software in this class has the ability to work offline. But I'm never asked the flip of this question, which is, okay, I recognize this probably has to work offline, but is there things you could do if you were online that you couldn't do if you were offline? I'll just tell you how we think about these internally. Yes, we could deploy this software so much cheaper. We could deploy it the way Kaiser Sepsis Calculator is deployed, which is a very low cost, reaching the entire planet that's connected to the internet. The other thing we could do is we could do real-time alerts. Right now, offline, we can help people deal with constraints. Online, we could link them to resources. You've entered a baby who is jaundice and you've said you do not have phototherapy. There is phototherapy at this hospital. Here's that phone number. Those are the type of things you cannot do when you're online. I would say broad themes of these questions. Can this work in my context? These are very good questions. There's nothing wrong with this question. Questions we ask ourselves: what if your context changed? Just recognizing that there's uncertainty in what's going to happen in the future. Second most common question I get asked, though not as commonly asked in the United States, where people are much more concerned about data vulnerabilities, is does this integrate with the electronic health record? Question we ask ourselves, and I would say about any new functionality, is how does this affect our hazard analysis? What could possibly go wrong? And when you add in, patient identifiers in an offline tablet, this is like putting a rattlesnake in your house. You have to have a really good system to know where that rattlesnake is hiding. For us, we think about things like, the horrible war in Ukraine, where there was targeting of maternal hospitals. How quickly could we get our software in the hands of generalist emergency medicine physicians for the Red Cross? Like, we could do that today. There's nothing that prevents it because we've designed it so we don't have these data vulnerabilities. I would say something, I would probably put this in the opinion category. This is my opinion that you see a lot of software that is studied in academics where they're trying to demonstrate clinical outcomes, and that leads to tracking patients, where I don't think you actually need to track patients to improve clinical decision-making. And it's just a risk that can be easily avoided. I would say a theme of this question is, what happens if you add this? Can you add this? And on our side, what happens if you add this? Imagine when the studies are done and you're trying to get someone to adopt this. Even if you give someone the software for free, they have to sign a contract, and that contract is going to go over all the data vulnerabilities and who's responsible. I would call our approach the empty wallet. There's nothing there to steal, and there's no patient identifiers. That makes it a much easier conversation when it comes to using it. Something I get asked, we see a lot of softwares and, they all kind of like do a little bit and they never get out of pilot stage, and there's a lot of duplication. I have to say, I just sort of reject this view of the landscape. For me, I compare newborn mortality, which is the area we're working in Uganda, with climate change. In climate change, I see just bold risk-taking on things that are very unlikely to work, just in case they do work. I don't see that sort of risk-taking from funders, from anyone, to try to solve newborn mortality, to really try numerous things at a level that would be successful. When I go to meetings about software, I'm like, where is everybody? There are a number of groups that are going after targets, but that number should be 10x, and we should really be competing. The last question we're asked is about the clinical outcomes. So does this reduce neonatal mortality, for example, from Dr. Muhindo's work? There are sort of two parts to this. The first part is the cost of studying something like neonatal mortality is high. and it's a multi-year process. So if we were to undertake that, we would need a funder who wanted to do that. And we want to pause everything for a number of years, during which time the software would likely iterate. But again, I go back to the user. Who is the user who's concerned about reducing neonatal mortality? It's actually usually a nation. You know, the nation of Uganda has a committed plan to reduce neonatal mortality, and it's a Ministry of Health. But the Ministry of Health, as a user of NoviGuide, has actually numerous problems, of which neonatal mortality is one. So from our side, we ask ourselves, okay, well, we have a pretty good software for newborns. We feel like we have about 90% of the illness you would encounter in a district hospital, and certainly the top targets. What if we had that for the top 20 health targets? You know, children, adults, you know, what if we had it for the top 50? What if we had it for the top 100? What sort of study would we do then? The second thing is the data. So there's this idea on the point of care, like someone follows this guideline and they're likely to maybe deliver at least a more systematic care. But the data itself has a value. For example, if I told you right now, go to this site, you'll find every single hospital that's out of gentamicin in Uganda. Well, that has a value, even if it's not in a reducing neonatal mortality value. The second thing I think sometimes when I get these questions is, no one ever puts a paper guideline up against that test. You know, we see big fanfare on announcements of new guidelines, new toolkits, but those are never put up against that sort of test of could the paper document, the one that's requiring in-person training, people going out in Jeeps to do training, those are never tested in that same way. There's not that bar to clear before adoption. I think of the story of a man who goes to a butcher to buy a chicken. He picks up the chicken, he looks under its wing, he looks under another wing, he looks under each leg, he looks at the eyes, he looks at the mouth, he looks at the tail, and finally the butcher says, I don't think you yourself could pass this test. That's sort of the thing I see with digital. I don't think there's not a software we use that's mortality reducing, and yet we all recognize inherently the value of having the digital processes for a lot of our healthcare. I'm going to conclude, since I'm the one holding the mic here, and then we'll take some questions, that building and studying software is a lot of fun. It's probably not something you thought about in your global health careers, but I would highly encourage you to think about it. It's certainly in the direction that the future is going. So maybe with that, I'll conclude, and Mary and I can take some questions.
That sounds good. Thank you so much, Josh. Thank you, Dr. Mary. I really appreciate your insights and your thoughts and your perspectives and your parables. I always enjoy those too. The floor is open for questions, and maybe I will pose one to the audience just to keep the conversation going a little bit. What's, for here working in many different contexts, what has been your interaction so far with electronic decision support tools? Do you use any, and what's that been like?
Since I don't see anyone responding, I'll just maybe add in that decision support is ubiquitous. That's what I tell our team. It is ubiquitous. It runs in the background if you're in the United States a lot of the time. A few times you're proactively seeking it out for common if you're in the newborn world, things like jaundice, things like Kaiser sepsis calculator. Those are kind of ones you're proactively looking at. But remember, decision support is also operating in the background. I gave an example of, if you've been familiar with the US setting, you open a baby's chart, it will tell you if the mother's syphilis has not been tested. That's a form of decision support. How does your doctor know you're due for the flu shot? They're getting a reminder. That's a form of decision support. So it's really permeates the landscape, I think, in the US context.
Yeah, let me ask Ted or Jason or Matt, who are first and second year residents at UCSF. Have those types of tools been helpful, or are they more cumbersome? Or what are your thoughts on some of the tools that you use in the US context?
I mean, as a brand new resident and intern, it's always helpful when the technology can step in and make things a little bit easier to take some of that cognitive burden off of us. You know, the digital health kind of world in the US is obviously very different than what you would expect to see in other parts of the world, and then also significantly different from what you would see in less developed countries. So I guess the question that I would want to ask is, like, what kind of, I guess, how does the development of creating decision tools for or for kind of these global health scenarios compare to what you would do in the US? I know that there's just a great number of more resources, but are there, I guess, key differences that would not work in kind of these global health contexts? Because I'm just much more used to thinking about development of software in these in our resource-rich environment. So the lessons that you kind of laid out were great, but if there was maybe a single point of failure that you potentially identified, or maybe misconception from like a developer perspective from porting something that might have worked in the US to these global health scenarios?
Yeah, that's a great question. Maybe I'll take that one since it has to do with kind of the US side of this. So I'd say, just speaking in general terms, the challenge in a setting like Tororo is decision support that can adapt to resources. The challenge in a setting like San Francisco is the complexity of medicine itself, and institutional variation. Now, what we learned was one crossover was, look, if we need to have the guideline vary, whether you have a resource or not, that same technology on the software side is very similar to, we do it this way here and you do it this way there. So you could actually bring over variation in resources and make it variation in anything, and that was like a crossover area. I think in terms of like times when we've had something that just like didn't work, I would say one big difference from the Uganda work to the United States work is, in Uganda, we focused on large assessments. So we're going to take you all the way through from a preterm baby being born to like they're sort of tucked in on a respiratory treatment, getting antibiotics, glucose, and we've thought about HIV. In the United States, the complexity of medicine sort of prevented those sort of large assessments, and people didn't need that as much. So you have these like tailored, I would say, like jewel box assessments. One you might think of is, the management of a well baby's glucose. There's actually a lot of moving parts, right? Like the treatment depends on the past treatment, but the shape of them looks very different. So if you imagine you're going to draw out the decision tree, in Uganda, it would go like across the screen, a very long pathway. In the United States, we're looking at pathways that are much shorter, kind of in a diamond shape, that take you through elements of a complex pathway. So I think that's something we learned, is that there's not the hunger for this. The second thing I learned is that, I feel like we really nailed it with contextual drug dosing. It's like, wow, people really do hate calculating gentamicin, so much so they'll use this app. But in America, that contextual drug dosing is not the driver, because those contextual drug dosing is often built into the order entry. So learning what was the driver was like starting over. And the only advantage we had was home field advantage. We knew this kind of work. What we came to was medical documentation and decreasing liability. Those are the two drivers in the United States. That then informed the targets you go after. So you go after higher liability targets. But you learn more, they're more similar than they are different.
To that point, I actually had a quick question. I was trying to figure out how to ask this the whole talk, but one of the things I was thinking about is, we talk about clinical decision support tools here in say like a large medical center context as being, just that, like being support, and to not really be the driver for your actual medical decision, but to really be supportive of that decision. And so I was curious from your perspective in building these tools, how you, I guess, how you factor that into sort of a more resource limited context, because oftentimes the sort of the drive in those contexts, I could imagine, would be to rely heavily on a decision support tool. And so I guess, how did you work to mitigate that sort of that temptation to rely on something when that might be one of your few resources you have, which could then be sort of pulling you to maybe make a decision that might not necessarily be the most medically advantageous decision, if that makes sense.
It does. Mary, do you want to talk a little bit about the training that people get to use the Novi Guide?
Oh, yes, that's a good question. So before each of them uses the Novi Guide, we take them through the way of how to use the Novi Guide and, of course, the guidelines. And by following whatever Novi Guide tells you to do, you're definitely following the Ugandan guidelines. So you're less likely to make a mistake if you're following it to the T, because it guides you. And like Josh said, because of the simplifications, the saving of time, the calculations that you're given automatically, you're more confident to give that gentamicin dosing because it's the right dose. You're more likely to give that ampicillin dosing because it's the right dose to give. So they use the Novi Guide, provide the care that needs to be given when they use Novi Guide compared to before.
And I'll add to that part of the training is what to do if you encounter a situation where you don't feel the Novi Guide is correct. And I would say that's a difference in the United States. In the United States, like sort of like, that would be like kind of obvious, you should not follow this, where if someone tells you this aligns to your guidelines and it's doing something wrong. So a lot of it is around, if you find something that you think is wrong, what you're supposed to do, which is A, don't follow it, and B, you can actually communicate back to either the principal investigator in our case or directly through the Novi Guide application backwards. Then the last part is what Dr. Muhindo mentioned, which is like, you don't just say it aligns to the guidelines. There's like this rigorous process of testing it with the people who wrote the guidelines. And that's another difference, Africa to United States. So we don't have like an equivalent national guideline. So the people you need to meet with are extremely busy people who are dealing with like national decision making. And that's just a process. I mean, 2 weeks to go through every single thing. But I think it's also one where it's like, you're right, it's like a key safety piece is that you want people to follow this and to reduce errors at the same time, knowing that it cannot account for all patient variation. And we could all come up with a case where you're like not supposed to bag mask a baby, even though that's the standard NRP for everybody. And that comes down into, you don't just drop it in. You don't just drop it in. You're sitting there training. The training for Novi Guide is scripted. There's a video as well that people watch, which instructs on not to do this if you think it's wrong. It's a great question, though, because it's definitely one we think about on our end. I would say this is even a bigger challenge for community healthcare workers. So that's a question I ask the community healthcare worker team is like, well, what if you encounter a case where you wouldn't know what the right thing to do was by virtue of the training?
Yeah, it's an important point. Would love to draw in some others into this conversation, Dr. Eileen or Dr. Celia or others. If you've used tools like this, would be interested in hearing your experience with them, or if you haven't, what have been the impediments to doing so? And maybe while you dwell on that, just a question for Josh and Mary on the concept of user feedback. You were mentioning some of the challenges of being online and offline, and I imagine that impacts this conversation. But if someone were going through using it and said, this is not useful to me because of X, or I wish this was changed over here, is there a way for them to inform the development of future iterations of the guidance?
Definitely. So yeah, you're right. In order to send a feedback, you have to be online. But for sure, when it's rolled out, you're like, and here are the contact people. And usually there's a point person at each facility who's sort of this Mary's work actually, but then the Novi Guide nurse who you would call if there was a problem. And then the online is like even more wild, because then you hear things like today I heard from Congo, hey, we don't have gentamicin, we have amikacin. And it's like, okay, like the feedback can come in like really informing the design. For me, it's a safety step. Like I get very nervous about software that doesn't have a way to contact you. If you find something, so we can fix it. And we hear this actually, like Mary has been key person in kind of getting this feedback from the teams.
I have a question. I was wondering how you see this scaling up, just because I think a lot of us know that software is helpful, and there's a lot of studies that show, at least not necessarily studying the software itself, but show that software as an adjunct for clinical decision making is helpful. But it's always like those studies provide a tablet, and then the study ends, and then everything is kind of done. So I'm just kind of wondering, like, who do you anticipate, like, as this gets more widespread, taking this on? Like, is this something that ministries of health should start doing to sponsor like software development and making a clinical guideline electronic? Should they help people get devices? Should they help people get access to load this on their device? Is the idea that people would be able to use this eventually on their personal devices, because those, you know, smartphones and everything are becoming so ubiquitous even in low resource settings? Or where do you see this becoming, like, how do you see this becoming a widespread thing, like across Uganda or even across, you know, other low resource settings?
It's a great question. I think broadly, my answer to that is we have to prove that it's cheaper than the alternative. So while people often ask us about like clinical outcome studies, I'm much more interested to show this is way, way cheaper than the way you're doing this now. Even printing one book, one guideline book, is almost the cost of a tablet. It's as crazy as that sounds. That's about what it is. And so you have to prove that it is this. And so I think that's where we're going to be looking to work with larger partners to do these cost effectiveness studies. Then the second part related to that is to drive down the cost of this. Let's just load it up with as much as we possibly can, so that this is cheaper than the way you're doing this for newborns plus OB plus non-communicable diseases plus HIV. And now you're suddenly saying, look, a single device is going to take you through all of these guidelines. Like, this is just worth it. The part I find in many people put this in like a class of device. It does training. It's point of care training, but it's still the same concept. For me, I think our best argument is staff turnover. That is the argument against doing this in person. Though we all love, you know, kind of being, it reminds us of our own training, you know, sitting in a lecture and hearing about a clinical topic and engaging on it. But if I told people you're in that lecture, 30% of the people will be gone in 3 months, would you still give it? You know, it's not worth it. It's not the way to transmit whole classes of information. It's a good way to teach hands-on procedures. It's a good way to teach some of the intangibles, but it's not a good way to teach this. And so that's how I see it. Laterally around topics, driving down, improving the cost effectiveness. I think that's how we're going to have to do it. So if you have any ideas, I'm certainly open to it as well.
I think it's always money.
Yeah, but people spend money on this, right?
Yeah.
So I just like, you know, and people spend money on hardware. So one of the things about Dr. Muhindo says, like, you're going to buy, you know, people are selling CPAP machines for these settings. Are you going to buy one when you're not sure it's going to have the impact that's been promised? You know, wouldn't you like to know people are using it? There's a lot of value, I think, in doing this. And then the remote monitoring piece is really wild. Like, it's, you know, it's a Google Map data, you know, it doesn't need to know who the driver is, but it can tell when they're hitting a roadblock. I'll give you an example, like, you know, a site that never identifies jaundice. You know, we could pick that up in the Novi guide, where you could not pick that up with a single other way that I could think of. Because you're looking for like the dog that didn't bark. It's like something that's missing from the medical record.
Thanks. There's a question around you know, who's helping support the development and implementation of some of these tools?
Yeah, it's a great question. So the software that we're showing you today is made in a nonprofit called Global Strategies. And it's been kind of one of the flagship programs of that group. And I think the future of this is in part what you see from the work, which is, I think this is a global problem. And it's not one that's limited to any specific country. And there's a good case for the same technology working in the United States. In terms of where this is in a setting like Uganda, it is still primarily, research dollars that are funding studies like this, but I don't think it's going to stay that way. I think people are recognizing that we cannot keep going in a paper-based system from WHO to a printed PDF. It seems very 1980s, and that we need to evolve forward. So I anticipate more investment in this area as people try to prove these out, and we want to be there to kind of show our approach. The other thing I would tell people is like, platform technologies, please. We all live here. Those of us who live here in California are living in Silicon Valley. And one of the lessons we have to take from our colleagues in technology is platforms. Platforms is how you make enormous change, not a Netflix show, but Netflix, itself. And you see too many projects that are really like a leaf on the tree, that were never designed to be scaled. Like, something I've learned from doing this, and I look at different projects, is not to say this project will become a pilot and never escape it, but rather by design, this project is a pilot. It's a pilot by design. It's not designed to take flight. And platforms, I think, are really how you avoid some of that. Put another way, there's not an algorithm that you're using in your clinical world right now that we could not turn into an app in a week. The one platform, there's an example of a platform you can point to, like, what am I a fan of? One of my favorite products is UpToDate. Not because I use it a lot. I don't know if how many of you are familiar with this. There's like no faces on the video, but UpToDate, for those of you who don't know, is sort of like online encyclopedia for doctors that people pay for. And when I was in medical school, this was like a laughing stock. If you said that you found the answer on UpToDate, your professors would look at you like you just Googled it or asked a random person what they thought about a medical problem. Today, every single hospital has this, including in Africa, where there's a big Africa program. That's a platform, right? It's like a platform for dispensing medical knowledge in an article form, and it has an enormous reach. It has a much larger reach than the WHO, in my opinion, about how people are actually doing things. Every time I see an article about decision support, Ted asked, is any in the global health? UpToDate is in the global health. In terms of platforms outside of in global health, I have to think about it. But that's an example of one that I really like, where it's just like, they were able to build this platform for dispensing medical knowledge that is really impressive and very vast. It's a great example of such a one. And that's a for-profit company, and but it's solving a key problem. Like, those professors who said that back then, those professors now write for UpToDate. They're top professors who write these articles, and something people thought would not work. The reason it works, the reason people subscribe to it, is not a single disease solution. It's like anything you would need to find, you could find in there. I'm trying to think of ones in global health that I like. I think there may be some in inventory management that I have to look it up. Any other questions out there?
Yeah, any questions from the group here? I will corroborate the utility of UpToDate and its usefulness as a platform. I think that's an interesting analogy. Sometimes I'll search and using the same terms, find updated information or a new topic altogether that seems even more niche and relevant to the clinical question I'm asking about.
Yeah. For people who do clinical decision support, one of the most common areas is in emergency medicine, because it's very algorithm based and it's high liability and you don't want to make a mistake. And oftentimes people will test decision support and they'll come to the conclusion that the decision support would have worked had people used it, but they didn't. Why did they not use it? If you read this literature like we do, what you'll find is people say, I didn't use it because I'm too busy. I'm an emergency room doctor. Haven't you ever been down here? Yet those people still use UpToDate. So that to me was always like, but wait a minute, you're using something, it's just not this thing. You are busy, but not so busy that you won't pause to get the right answer on something. So it's been a really interesting work, and in a whole other talk, I could talk about what I've learned from emergency doctors, because that's where our work is in the rural United States. It's true. One of the things mentioned is bias. Bias is like a huge challenge where clinical decision support could improve, and could improve by reducing bias. One of the areas that we're looking at is a patient-facing, client-facing app for determining whether you're eligible for prenatal aspirin. It's like a huge health disparity target. And we know that some of those disparities are related to biases. Well, thanks for the opportunity to come and speak again this year. I'm glad Mary's internet connection held up.
Thank you. I really appreciate your time and your insight. Dr. Mary, any final kind of words or comments from your end?
Oh yeah, thank you. We're so grateful that you've given us this opportunity to talk about our work. And I hope many of you will join us.
If folks do have questions or other comments afterward, would it be all right for you to put your email addresses in the chat, or for me to refer them on to you? Okay.
Sure.
And with that, I think we'll go ahead and close. For those in the UCSF or Ugandan